Hello surgeons, this is a patient with a moderate open-angle glaucoma and he cannot tolerate the topical medication, so we decided to go for the Preserflo implant. Let's start with subtenor anesthesia and let's put a traction suture 7/0 vicryl in the peripheral cornea, and let's pull this eye down and start our conjunctival dissection. Usually we like to put it in the superior nasal quadrant, so we leave the superior temporal quadrant available for future implant or bigger implants like Pole or Ahmed valve if needed. But for small tube like Preserflo, superior nasal should be sufficient. And always try to dissect between the recti muscles. Don't put it directly over the recti muscle insertion or like near the same meridian, because the fibrosis risk is higher. Now putting a subconjunctival and subtenon mitomycin in the posterior area of the dissection. This spear is soaking the mitomycin and is keeping it in place for around 2 minutes to 3 minutes. That's fine with a concentration of 0.4, especially with the darker population, because they have thick tenons and a higher risk of fibrosis. Now washing all of that mitomycin, and let's get the implant now, and let's make sure that it's patent, priming it with the BSS cannula. And we have to notice like some Mountain Dew dripping, and that is noticed in here. And then after that is done, we're gonna grab the caliper that comes with the set, 3 mm behind the blue zone in the limbus, superior nasally, and then we start our tunnel halfway through between these two dots, and then we continue to the AC with this 25 gauge needle that comes also with the set and enters the AC above the iris. Now after that we're gonna grab the McPherson's, and then we're gonna start pushing this implant, and we can see the tip superior nasally in the AC with good positioning. Now it's better to check if there is a flow. Apparently there is a flow, like there is Mountain Dew effect here, like a dripping gently and slowly. Some people leave the tube as it is, just like approximate the tenons at the top of it. However, we suture it in our facility with the 10-0 nylon, so it doesn't kink, it doesn't tent, and it doesn't hit against the tenons. So X-figured 10-0 nylon is being sutured here to flatten the tube on top of the scleral tissue and keeping it away from the tenons above. Now after that is done, we're gonna suture the conjunctiva and making sure that we take within the bite we take the tenons, otherwise the tenon will retract and go posterior and cause fibrosis over the tube. So some surgeons prefer to suture the conjunctiva and the tenons separately, so tenons first and then conjunctiva. But here we suture them together, but only after making sure that the tenons is pulled anteriorly and taken within that bite. Now all these sutures must be watertight, so suturing all the areas of the dissection, and 10-0 nylon is a good choice here. We try to avoid the vicryl because it causes more fibrosis, and we don't want that on top of such a small tube that is at higher risk of fibrosis and blockage. More suturing is happening, and it is better to bury those sutures so they don't rub against the tarsal conjunctiva when the patient blinks, and usually we remove them after 2-3 weeks if we notice good healing post-operatively. Thank you so much for watching this case, and have a great day.